Hi guys, just want to do a quick recording to go over the review questions and also give you a couple tips for the exam coming up on Monday. Okay, the first case is this contraceptive case. This is a 23-year-old female who's been on the birth control brand Merced for a while, and she's having breakthrough bleeding. So what I've given you here is a table of 4 different birth controls. It shows the general relative potency of the different products in them. So I'm not testing you on specific drugs necessarily, but if you were to look up, what is a low estrogen or high progesterone or high progestin or high androgen product, you could figure it out maybe by that. So that's kind of the scenario I'm giving you here. The way to approach this is, first of all, you need to know how to treat breakthrough bleeding. So generally speaking, breakthrough bleeding is caused by low estrogen. A bit higher estrogen products can help stabilize the endometrium a little bit better, and that can help with the breakthrough bleeding. So right off the bat, you probably know that Merced might not be the best option for her. So continuing Merced probably not the best, because if it's breakthrough bleeding now, it's probably not really going to change much. Lacina, is also a low estrogen product, so you'd want to avoid that one. The other two, it gets a little bit more complicated. The way I laid out this question on the exam might be a little bit more clear cut, but Orthocept and Loestrin are both intermediate, so you're increasing your estrogen a little bit. Progestin is very high or high, pretty similar to Merced, and then the androgen is where the difference is. So what I'm getting at here is that you have 2 products that are pretty similar except for their androgen, and generally speaking, I didn't give you any other information about the patient, but you can probably assume that you don't necessarily want to change the androgen component of it to high androgen unless there was a good reason to do so, and I didn't give you any reason for that. So really the focus here is on estrogen. So with changing from Merced to Orthocept, all you're really doing is increasing the estrogen amount. And yes, the progestin is a bit higher of a dose than what Merced would be, but it's not going to make that big of a difference, whereas the estrogen should help with some of her symptoms. And you're keeping the androgen component low, which is going to hopefully maybe avoid some side effects associated with oral contraceptives. So B, change to Orthocept, is the correct answer. This case is about hormone replacement therapy. You got a 51-year-old woman. She's experiencing both hot flashes and vaginal irritation. Tried a number of things, including antidepressants, to help without success. She is healthy. She doesn't have a history of cancer, cardiovascular disease, or surgery. And she'd like to try hormone replacement therapy today. The first question is about side effects. And so just knowing the general risks associated with hormone therapy. So if you just remember that hormone therapy has a risk of thromboembolic complications, that's pretty much all you need to know to answer this question correctly. So while we don't have firm, perfect evidence that they substantially increase risk of stroke and MI, there is some evidence out there that shows it, but they definitely don't decrease risk, so A and B would be incorrect. That leaves you with D, an increased risk of DVT, and I think hopefully from the lectures you know that that's a risk with hormone replacement therapy and oral contraceptives as well. C, they should decrease risk of fracture, so that's one of the benefits they should have, so C is also incorrect. 2, which of the following treatments would be best to recommend for her? So first thing you need to know is that with patient with both hot flashes and vaginal irritation, you want something systemic, because if you gave somebody a vaginal product, just a vaginal only product, granted there are vaginal rings and stuff that absorb systemically, but we won't go there right now. So if you gave somebody like the D Premarin cream, that's not going to address the hot flashes, so D is crossed out immediately. The other 3 options, one is a combined product and the other 2 are estradiol only. So really the patch, and whether it's weekly or not, it makes no difference. What we're really looking at here is the actual drug, so estradiol versus combination therapy. And when it comes to combination therapy, when is it appropriate? Well, it's appropriate in any woman with an intact uterus, and I've given you, didn't come out and say that right away, but I did say that she doesn't have any history of surgery, so that should be an indicator that she does not have, or that she does have a uterus. If she had a hysterectomy in the past, either A or B would be fine, but since she does have a uterus, C is the only correct option here. The pregnancy questions, the first one is about a 32-week pregnant patient. She's 28. She has a history of migraines, used Imitrex, which was effective for her. She's in your urgent care. She has a migraine. It's getting worse. She has taken maximum dose of acetaminophen. Which of the following options would be safest? So this requires knowing that which treatments are okay for headache in pregnancy. Sumatriptan is not okay. Triptans are not used in pregnancy. Same with DHE, not also used in pregnancy. You can kind of lump that in with triptans as not okay to give in pregnant patients. Then you have metoclopramide and metoclopramide and ketorolac. Metoclopramide is category B. It's an antiemetic that's relatively benign and has good data in pregnancy. That would be the correct choice here. We don't use NSAIDs during pregnancy really at all, and especially not this late in pregnancy, so D would be an incorrect choice. So again, C, metoclopramide, is the correct answer. Which of the following medications would be first line for stopping preterm labor for a patient who is 33 weeks pregnant? So remember that in patients 32 weeks or under, NSAIDs are preferred. So indomethacin is the preferred drug there. But in this case, this patient's at 33 weeks, so that requires you to know which one would be an alternative. Nifedipine is generally the better tolerated alternative compared to terbutaline. So you try nifedipine, and terbutaline would kind of be your second line. So at this point, since I didn't give you any information about what she's tried yet, you would go with nifedipine as your correct answer. Pete's question, this is EJ, 1-day-old boy, so still in the hospital post-delivery here. Spiked a significant fever. He was breastfeeding initially, but has stopped eating now. His labs show leukocytosis. He's got mild tachycardia and hypotension, so he's almost looking a little bit septic. EJ's mother has no history of MRSA, but was on prophylactic therapy for group B strep during delivery. So that would be indicative that she has some history of group B strep colonization. Which antibiotic or antibiotic combination makes the most sense to start at this time? So in this case, I've given you some hints that there's probably not a risk of MRSA, probably some risk of GBS, but it's a 1-day-old boy. You know, these treatments are fairly straightforward. You're probably going to do something to cover the group B strep, which is going to be your ampicillin in most cases. And you also want something to cover gram-negative, so that's where like cefotaxime would come into play. You could do gentamicin, but something to pick up some of those gram-negatives that are sort of the unknown factor with the infection. You might be fairly confident it's a group B strep infection, but you don't know what else could be growing, so you want to cover your bases. Levaquin we don't really use in kids. You wouldn't use it in this instance anyway, and you wouldn't use it in a kid this young most times. Amoxicillin clavulanate or Augmentin is a PO product, which wouldn't be appropriate in an infection this severe. C is the correct answer, and then D is also actually correct, it's just not the best answer. So gentamicin plus vanco is fine, but we wouldn't use it because you don't need vanco in this case. Vanco is a more potent gram-positive agent, and it's usually reserved for MRSA. So unless you knew that it was MRSA, there's no reason to start vanco. Vanco will work for group B strep. It's just going to be a bit of a slower killer than ampicillin, so that's another reason why we'd prefer ampicillin over it. But vanco plus gent would be an appropriate combination, but more for other scenarios, specifically MRSA infections. Alright, second Pete's case is a 2-month-old girl recently had surgery to correct her transposition of the great arteries. Post-op day 1, doing well. Blood pressure is pretty stable. Cardiac output is a little lower than desired, so which of the following IV infusions would have a positive inotrope effect but minimal change in blood pressure? So this just requires knowing which one is basically a pure inotrope. There are 2 pure inotropes that we use, milrinone and dobutamine. I just gave you one of those, so milrinone is the correct answer. Choice D. Choice A and B, dopamine and epi, are both they're both positive inotropes, but they also are pressors, so you're going to increase blood pressure substantially, and that's not what we want to do in this case. Nitroprusside is not a inotrope, and it's a vasodilator, peripheral vascular dilator, and it's going to decrease blood pressure, and that's again not something we need to do, and it doesn't have the inotropic effect we want, so we won't use nitroprusside in this case. So D is the correct answer. Alright, so those are the few questions. Hopefully that's somewhat